All right, well, we're going to move right on to the AAPS academic scholar presentation. I'd just like to say a few words for those of you who may not be familiar with the history. A number of years ago, we actually combined the interest with the three named academic scholar funds. That's the Furnas Fund, the Hoops Fund, and the Peer Fund, in order to continue annually to fund this $30,000 per year very prestigious award. This gets into the 110-100 situation, and our hope is, with getting this fund up to $5 million, a total of $5 million, is to allow us to fund yet another academic scholar, have two academic scholars per year at this great meeting. So with that being said, the Academic Scholar Award this year is the Furnas Award, and Benjamin Levy is going to make his presentation. Ben?
Thank you very much. It's really humbling to be here and a true honor to receive this award, which has made a huge difference for our laboratory and our group here and our fearless leader, Dr. Sedurna. So never had disclosures before, but thanks to the funding of the AAPS, this research is funded by the AAPS, and due to the research that we've done, we've been able now to link up with other groups, including Boehringer Ingelheim, that works on specific therapeutics to treat a disease process that we study, as well as several patents that we work on that have not yet been licensed. So our laboratory focuses on a process called heterotopic ossification, which a lot of you know is a process where bone forms outside of the skeleton. As a burn surgeon, I see this in our burn patients. As a plastic surgeon, we see it in pressure ulcer patients, spinal cord injury patients, and we get referrals as well from patients with traumatic fractures, as well as joint replacement patients. Now, the current treatment strategies, I think, for these patients are really inadequate, and I like to show this patient, who's a patient I took care of as a trauma chief, who had a 70% burn, and when you get a patient through a 70% burn, you feel pretty good about yourself, but then when they come back to Dr. Sedurna's reconstructive clinic 6 to 8 months later, unable to extend their elbow, you no longer feel as good about yourself. And really, what we notice is that the treatment for these patients right now, what we do is we wait for this to develop. They have these horrible contractures, chronic pain, and then we do surgery to reconstruct it. And this, published by Dr. Sedurna and Dr. Kung, at their experience doing reconstructing the heterotopic contractures that form. And you can see here that clearly post-op, these patients have improved range of motion from pre-op. But we really think that the whole approach should be different, that I should have been thinking about this when this patient was in the burn unit, and I should have said, okay, this patient's high risk, and I should give him something to prevent this process from ever occurring, preventing the need for future surgeries. So what our lab tries to do is to identify patients that are high risk using specific technologies, and then giving them a short course of prophylaxis to prevent this process from ever occurring. So what we first had to do is develop a model that we think predicts this. This is a polytrauma model where mice get a burn injury and then a tendon injury to their extremity, and they develop heterotopic bone at the site where they have their tendon injury. These mice, like in our human patients, they get joint contractures, and the heterotopic bone is an endochondral process, just like in limb development, with cartilage forming first. One of the problems with this is even after it forms and you cut it out, there's a high risk of recurrence. And that's why, again, I think early prevention is so important. And in our model, we see the same thing, where if you resect it, it does actually come back. So for early detection, we use several different technology. We started out using near-infrared imaging, which allows you to see early bone lesions much sooner than we would see by a normal CT scan. And then an outstanding postdoc, Kavitha Ranganathan, in our lab has been working on looking at ultrasound, which normally ultrasound reflects off bone. You can't actually see bone with an ultrasound, but you can alter the B waves, which she's done, and then you can see some of these early lesions which form a lot sooner than we would see by CT scan. So this is something at the bedside. Obviously, we take the ultrasound to the bedside on patients and perhaps detect which patients are going to develop it. So if we have technology that we can detect what patients are at risk, what can we do next? And can we prevent this from occurring? So this was a patient I took care of in Boston who's had a traumatic amputation of the leg from the elevated rail. And when resecting the heterotopic bone, notice that the bone is a lot more vascular than just cutting into normal cortical bone. And despite early preoperative embolization, this patient had quite a bit of blood loss. And if you look back in the literature, there's a lot of reports on the early inflammatory or vascular swellings that foreshadow heterotopic bone. And also, there was a paper in Nature in 2009 that said that the blood vessels, those cells were actually the stem cells that formed heterotopic bone. So we wanted to see if that was actually the case in trauma, and that was the purpose of some of our studies. So we looked back at an array of 260 patients at high risk of developing heterotopic ossification, so burn and trauma patients. And we compared that to control patients. And what we saw is that those genes associated with blood vessel formation, so VEGF was upregulated, but also HIF-1 alpha or hypoxic signaling was upregulated. So then we said, okay, if it's a hypoxic lesion and early vascular cells are important and are maybe the stem cells, should we be targeting this? And are these actually the stem cells? So when we look in our lesion here, so in normal leg anatomy of a mouse, there's some blood vessels, as you can see the lower extremity, like normal, but when you have the heterotopic bone, you can see a lot more blood vessels forming. So it's a hypervascular lesion. And then when you use a different model here where the mouse, every cell that's an endothelial cell turns red, you can see that the blood vessels kind of course out from the bone marrow, and this lesion, the heterotopic lesion, is very vascular. So there are blood vessels there, but are those actual stem cells that are forming it? And that was, again, what had previously been shown. To really do this, though, what you need to do is set up a model where you wait till the mouse is an adult. You then label all the cells red by injecting the mouse with a system, a tamoxifen system. So then every cell that ever was an endothelial cell turns red. So that can tell you, are these the actual stem cells? And if you look here within the green arrow here, and within the green line where the heterotopic bone is, or here in the yellow, there are really no red cells, right? So that thought that these were the stem cells actually is not true. Now, there's a lot of them around the area, so it's a vascular lesion, but the actual stem cells aren't stem cells aren't vascular origin. So where are they coming from? So we look back at our patients, these are often in sites where there's a lot of connective tissue, right? In the elbow, where there's entheses, or in the Achilles tendon, where tendon inserts on bone. This was a lawnmower injury patient I took care of. So are they connective tissue stem cells? And for that question, we used a different model where cells that are connective tissue or mesenchymal stem cells are green. You can see the tendon is green, and the entire heterotopic bone lesion is green. So it actually is a connective tissue or local stem cell that turns into bone from trauma, not an endothelial cell. When we use another model that mimics kids that have a mutation that develop heterotopic bone, we also see in the muscle that the heterotopic bone isn't in the myofibers, it's along the fascial planes, which is similar to what we see clinically. This is fascial connective tissue disease. Sean Loader, an outstanding student in our lab, then wanted to see if these cells were all local cells or whether they came from the circulation. To do that, we use a model where we take a mouse that's labeled and one that's not, and they begin to share circulation when you sew them together. And if you injure the unlabeled mouse, any cell that gets there you knew came from the circulation. And basically what he showed is that most of the cells did not come from the circulation, that they were local. So local stem cells, connective tissue cells exposed to trauma turn into bone. So my hypothesis from this grant was that we could prevent it by targeting blood vessels. So is that wrong? As it turns out, though, HIF-1 alpha, which is upstream both of vascular signaling, is also needed for cartilage. And as I told you, this is an endochondral process. So cartilage forms before bone. So if you target HIF-1 alpha, not only are you blocking some of the early angiogenesis, you're blocking cartilage formation. And Shailesh Agarwal, who's applying it in micro right now, also what he looked at was if you look at hypoxia at this injury site, we did not see, we saw a lot of hypoxia at the site where heterotopic bone was going to form. And when we used an inhibitor of HIF-1 alpha in these mice, we were able to decrease the amount of heterotopic bone in our burn tsunami model. To make sure this wasn't just model specific, we worked with the group at the DoD. They do a rat injury where they get a blast, amputation, and MRSA infection. They normally get heterotopic bone. When treated with an HIF inhibitor, even for a brief course, they didn't develop any heterotopic ossification. So then we have our pathway and we have our stem cell. If we knock out the pathway in just those stem cells, so HIF-1 alpha in the connective tissue stem cells, as we did here, you can see that basically no heterotopic bone forms. There's no pre-cartilage formation that forms, so you're really targeting the right stem cell and the right pathway. Can this carry over to fibrodysplasia ossificans progressiva? Again, this is a rare disease where kids develop bone throughout their body, really debilitating. And when we use a mouse that has the same mutation that these kids have, and we treat it with the same treatment, we see, again, a decrease in the bone that they form. Now, this is a musculoskeletal disease. It's not just bone. If you look around the bone with MRI, there's a lot of fibrosis around it. And Dave Cholak, a student who will be applying to plastics next year, was shown, if you look at the actual fibrosis and fibrotic accumulation here, that when you target the same pathway, that fibrosis doesn't form. So since receiving this award, we've been very lucky with regards to publications and presentations, intramural and extramural funding. Most proud of those for our mentees, both F32 and Howard Hughes for our residents and students, and mentorship from people within the AAPS. Hopefully these people that worked on a lot of this work will become future AAPS members and scholars. And ultimately, this is a clinical organization, and we have changed our clinical protocols at University of Michigan in our burn unit based on these findings. This is what we currently do now in our burn unit to prevent heterotopic ossification, hoping to expand that to other burn centers across the country. And we've been very active with the International FOP Association, which treats kids with congenital heterotopic ossification. We recently had one of the families come visit our laboratory, and some of the work will lead to a clinical trial in the future. I want to especially thank Dr. Furnas, who this is named after, who has done tremendous research in burns, everything from reconstruction to inhalation injury, as well as bone research across many different areas. And three of the first 5 winners of the AAPS scholars have been mentors, Dr. Kuzan, Dr. Longacre, and Dr. Sederna, who has been incredibly helpful in our laboratory workings and in his mentorship. So I just want to thank everyone. Thank you so much for this award. It's an incredible honor to be here in front of you today. Thanks so much.